Okay. Welcome everyone, and thank you for joining us this morning. We're very pleased to be hosting a webinar on the path to elimination of mother-to-child transmission of HIV and syphilis. We have a panel of presenters. Our first presenter, Dr. Shafiq Asaji, is the lead for PMTCT and maternal, newborn, and child health for the HIV department of WHO. And his presentation will focus on the elimination and pre-elimination criteria for the validation of MTCT of HIV and syphilis. And then the second presentation will focus on the process and the tools for elimination and for the validation process. And that will be delivered by Dr. Innocent Nuagira, who's a medical officer for monitoring and evaluation based in WHO Harare, Zimbabwe, and he's also the IATT M&E specialist. And we also have joining us Miriam Chipimo from UNAIDS, who will talk a bit about the human rights tool that's a part of the validation process. So we're glad to have everyone joining us. And without further ado, I'll hand it over to Shafiq to begin the first presentation.
Thank you very much indeed, colleagues, and to Jessica for organizing this. It's wonderful to see so many folks participating and great to see so much interest in this topic. Some of the information and slides that I'm going to present are draft materials because we haven't yet fully finalized and released all of the elements that I will be presenting today. So I would ask for you to bear with me. You may not be able to access these slides through the normal IATT mechanism. As soon as the official policy is released around pre-elimination, we will of course make these slides available to you in the usual way. So what I'm going to talk about is give you a brief global update on elimination and also introduce the concept of pre-elimination. Next slide, please, Jessica. Next slide, Jessica.
I'm changing the slide.
Okay.
Yeah.
I didn't see, it's not coming up. I'm not seeing that. But are others seeing the new slide?
Can someone confirm if you can see the slide?
Yes, I can see it.
Yes?
Yes, we can see the slide.
Okay.
I'm seeing slide 8.
Cuba.
8? It should be slide 2.
Oh.
Can someone confirm you're seeing slide 2?
Yes, I think it's slide 2.
Yes.
Slide 3 now.
All right. Let's stick with slide 2. This is of course taking us back a year to the announcement of Cuba as the first country to eliminate mother-to-child transmission of HIV, and that process took a long time and involved a complicated procedure for establishing Cuba's status as the first country to have eliminated mother-to-child transmission of both HIV and syphilis. And a lot of that process has really helped us to inform the global processes and criteria going forward. So I think it's worth recognizing the important role that Cuba had, and not just as the first country to achieve elimination, but also really as a trendsetter for determining the pathway that we need to follow for other countries that are seeking this. The next slide. So in order to achieve this certification, Cuba had to meet a number of impact and process indicator criteria. And these are shown in the table here. And basically, the impact criteria involve a mother-to-child transmission rate of either less than 2% or less than 5% among breastfed populations, and a case rate of HIV infections. This is a population-based case rate of fewer than 50 cases per 100,000 live births. There were similar impact criteria for syphilis, a case rate of fewer than 50 per 100,000 live births. And for both HIV and syphilis, there were process criteria that had to be met, including high levels of ANC coverage, high levels of testing for both HIV and syphilis, and high levels of coverage of ART for HIV and penicillin treatment for syphilis. Next slide. So since Cuba, a number of countries in Asia, Europe, and South America are close to being validated for EMTCT of HIV, and these are shown in red. And so they include countries in Europe, including countries like Belarus, Moldova, Latvia. They include a number of countries in the Caribbean and in South America, and also countries in South Asia and Southeast Asia, including Thailand as a possible country that is close to being validated for EMTCT of HIV and syphilis. Next slide. But what this shows you is that none of these countries are actually in sub-Saharan Africa, which accounts for 90% of the global burden of mother-to-child transmission of HIV. Next slide. And yet, when you look at the high-burden countries of sub-Saharan Africa, they have made significant progress in reducing PMTCT of HIV. So let's just tab through the next few slides, Jessica, and then I'll talk about each of these little graphics. So what you see here is that among 144 lower middle income countries, more than 80% are now using option B+, that's treatment for all HIV positive pregnant and breastfeeding women. As a result of this, among the 21 global plan priority countries, the rate of maternal ART has dramatically increased, and we're now seeing, on average, more than 2/3 of all pregnant women getting access to antiretroviral treatment. And the impact of that on the maternal-child transmission rate is also very evident. Since the inception of the global plan, we've seen a reduction of almost 50% in the numbers of new infections estimated to be occurring every year among children. So all of this is really tremendous progress. Next slide. And if you look in individual global plan countries and actually examine what their MTCT rates and PMTCT coverage for ARVs looks like, what you see is that in many countries, if you just click the next slide, Jessica, you'll see what those countries are. In many countries within the global plan, specifically South Africa, Botswana, Namibia are three that I've highlighted here in red. You've already got coverage of ARVs for PMTCT that are in excess of 90%, in some cases much higher than that, and you've got MTCT rates that are in some cases below 5%, such as for Botswana and South Africa, and for Namibia just above 5%. So you've got a number of countries that are very close to achieving these elimination criteria. Just click on the next slide, Jessica. You'll see that Rwanda is not shown on this graphic because it's not one of the global plan countries, but in Rwanda, ARV coverage is also above 95%, and the MTCT rate at the end of breastfeeding is below 2%. So you have a situation where a number of the high burden countries are achieving or close to achieving these other elimination criteria. Next slide. But let me remind you that one of the important criteria for defining elimination is the case rate criterion of fewer than 50 new cases of HIV per 100,000 live births in the population. Next slide. And if you look at the estimated case rates in the global plan countries, you'll see that for almost all of the global plan countries, the case rates are well above the elimination threshold. Next slide. Shows you where the red bar is, which is the elimination threshold of 50 cases per 100,000 live births. So if you click on the next slide, Jessica, you'll see that the three countries that I highlighted as being close to meeting all of the other process indicators, as well as the MTCT rate indicator for elimination, are well above the threshold that we need to reach for the case rate of 50 per 100,000 live births. So this is a very significant challenge for the higher burden countries, which will obviously have an impact on their ability to reach the lofty status of elimination of mother-to-child transmission. But the next slide shows you that there are reasons, I think, to be optimistic about this situation. And this is data taken from Lynn Moffinson's work for a remodeling of the Spectrum tool that was conducted last year. And what Dr. Moffinson did was to examine the MTCT rates for a variety of different scenarios. And as part of that meta-analysis, she also looked at MTCT rates that are reported for women who are on ART prior to actually becoming pregnant. And so there are various studies listed there, and as you can see, some of the smaller studies showed no transmission, so a 0% mother-to-child transmission rate. But even in the larger studies, MTCT rates were pretty low, and on average, around 0.19% at 6 weeks. So this is considerably lower than the traditional numbers that we've been thinking about, and it does suggest that as programs roll out Option B+, and more women are on treatment before they become pregnant, that we will begin to see the impact of this in terms of driving down observed MTCT rates in countries to unprecedented low levels. And that, of course, will open up the potential for many of these countries to achieve that very low case rate that currently has remained in use. So in recognition of this possibility for the future, next slide, what we've now done within WHO and some of the global partners, especially UNAIDS and UNICEF that have been working with us in this area, is to attempt to come up with a new category called pre-elimination, which is an attempt to specifically recognize the progress that high-burden countries have made in terms of eliminating PMTCT of HIV. So what this first slide shows you are the criteria for elimination. And if you look at the next slide, I've added here the proposed criteria for pre-elimination. Now again, these are draft criteria. They're not as yet finalized, so please don't take this away and say, oh yes, WHO has defined what these criteria are. They still need to be fully and formally endorsed by our Global Validation Advisory Committee and then officially released through the WHO processes before we can say that these are the final criteria. But I think this is where we're heading. We will keep the MTCT rate of less than 2% in formula-fed or less than 5% in breastfed populations. But there will be no case rate minimum for pre-elimination. And among the process indicators, as opposed to requiring countries to achieve 95% for ANC testing and ART coverage, we're now aiming for countries to achieve at least 90% for those process criteria. Next slide. The other critical element that needs to be borne in mind, and we will come back to this later on in the presentation, is that part of the achievements that a country has to come up with is not just the impact and process criteria, but also a defined plan on how the country plans to get to elimination for HIV and syphilis. So the next slide just delves a little bit deeper into the 95, 95, 95, and now the proposed 90, 90, 90 process indicators for elimination and pre-elimination, and compares them to the fast-track 90, 90, 90 indicators that I think all of you are familiar with in terms of the fast-track cascade indicators presented by UNAIDS. And so what those 90, next slide please, what those 90, 90, 90 indicators address is the proportion of people who are diagnosed, the proportion of those diagnosed who are then on ART, and the proportion of those on ART who are then virologically suppressed. And all of those have to reach 90, 90, 90 in order to get to the fast-track targets that we want to achieve. But the denominators, next slide, for the are distinct for each of these. So for the first of the 90 targets, the denominator is people living with HIV. For the second target, all those diagnosed, and for the third target, it is of all those treated. So the next slide shows you what it would look like if you assumed that the denominator was the same for all three targets, and that was of all people living with HIV. And what you see is that the targets are actually cascade targets, so that the first one is 90% of all people living with HIV diagnosed. The second one becomes 81% of all people living with HIV on ART, and the third becomes 73% of all people living with HIV who should be virologically suppressed. Next slide. So by contrast, the elimination and pre-elimination criteria that I've outlined are distinct from the fast-track targets because they have different denominators. Next slide. And what those denominators are is that for ANC, the denominator is all pregnant women. For HIV testing, the denominator may be either all pregnant women or all pregnant women with HIV. And for the ARV indicator, the denominator is of all pregnant women with HIV. Next slide. And what the message behind these criteria and the denominators that are being used is that we're trying to align them as much as possible with the GARPA indicators for PMTCT coverage. Giving countries a choice for their HIV testing denominator will allow countries to report either against the proportion of all pregnant women or of all pregnant women with HIV. And this is especially important in countries that have a concentrated epidemic, where you might be able to achieve high levels of testing of all pregnant women with HIV without necessarily following a universal testing approach in the whole country. These indicators, therefore, are intended to be independent measures of program efficiency. So they're not really intended to be a cascade set of indicators. Rather, they're each of them reporting against the specific program elements that are felt to be important in order for a country to be able to state that they have a robust program. Next slide. There are a number of additional requirements that a country needs to meet, and these follow four distinct areas: timing, geography, quality, and equity. The country has to have evidence of achieving the process indicators for at least 2 years and the impact indicators for 1 year. There has to be evidence that elimination has been achieved in the whole of the country, in all of these subnational units, not just in the country on average. And that is to ensure that there are no hotspots of transmission occurring within the country where services are not being adequately provided to the population. There has to be an adequate national M&E system that can capture data and detect the majority of cases from both public and private health sectors, and the criteria have to be met in a manner that is consistent with basic human rights and gender equity that needs to be part of the PMTCT program. Next slide, please. Now I want to touch briefly on the importance of syphilis. We don't talk about it much within the HIV community, but syphilis infects more than 1% of all antenatal attendees in one of 3 countries. Next slide. And the MTCT rates of HIV and syphilis and morbidity and mortality of congenital infection without treatment suggest that syphilis is even more transmissible than HIV, with a transmission rate of between 50 and 90%, depending on the maternal stage of infection. And that morbidity and mortality in syphilis is really very significant. You see 52% of perinatal deaths, that includes stillbirths, 31% of those morbidity events will result in congenital disease, and 12% will develop preterm or low birth problems. So really a very high risk of morbidity and mortality as a result of syphilis infection. Next slide. And this large burden of disease in syphilis is really preventable. So for HIV, we saw an estimated 220,000 mother-to-child transmission events in 2014. For syphilis, that same global estimate is in excess of 350,000, resulting in adverse outcomes, including 143,000 perinatal deaths and as well as stillbirths. So really a very significant burden of disease related to syphilis. And the impact of treatment, as with HIV, is very dramatic. Screening and treatment of syphilis-infected mothers up to 30 days before delivery can dramatically reduce transmission and thereby largely prevent all of this perinatal morbidity and mortality. Next slide. And I think that's one of the important driving factors behind the desire to have an elimination plan that is submitted as part of a country's pre-elimination dossier and that must include the following elements. A methodology for addressing, tracking, control, and prevention of congenital syphilis, retention both antepartum and postpartum in order to diminish the number of breast milk transmissions, addressing access to prongs 1 and 2 of the PMTCT prongs, addressing incident infection amongst pregnant women and breastfeeding women, addressing retesting of negative women in order to identify incident HIV and prevent transmission, ensuring that infant prophylaxis is strengthened and that MTCT rates are reduced by the use of more enhanced infant prophylaxis, and ensuring uptake of treat all as a recommendation to ensure that more and more women are on ART prior to conception, as we know that ART prior to conception results in a significantly lower rate of mother-to-child transmission. So just let me delve into that a little bit more and just remind you that the case rate calculation is basically a function of the maternal ANC prevalence and the MTCT rate. So if we want to see a case rate that drops below 50 per 100,000, those are the 2 parameters that we have to address. And these are the kinds of factors that need to be touched on in order to achieve that reduction. So the first is time. We will see an epidemic decline, and that will have an impact on maternal prevalence, especially as the current cohort of young women age out of their childbearing years. The second is family planning access. If you have fewer pregnancies, then you have fewer HIV-positive pregnant women. The third is men on antiretroviral treatment. The more that men are being diagnosed and identified as positive and getting onto ART, the fewer transmission events we will see. And then, of course, there are women-focused prevention strategies, including PrEP, condoms, which will result in fewer infections among women, especially during pregnancy and breastfeeding. And then the factors that affect MTCT rate include coverage of testing in ART. Even a small gap in coverage results in a lot of mother-to-child transmission. The timing of ART start relative to pregnancy, both early ART and preconception ART, have a large influence on the MTCT rate. Addressing incident HIV, which is associated with a very high risk of transmission through a number of interventions, including partner testing, PrEP, and retesting of pregnant women. And of course, critically, improving retention on ART in order to reduce the transmission risk during breastfeeding. I think these are the things that many of the higher burden countries still struggle with, and these are the factors that will need to be addressed in the elimination plan in order for that country to predictably and reliably achieve a transmission rate, a case rate below 50 per 100,000. Next slide. So based on the current levels of coverage, we think that 3 countries may be eligible for pre-elimination, and those include Botswana, South Africa, and Rwanda. The next slide. But I just want to underscore one thing that I think is important, and I know that Innocent will touch on this as well in his presentation. I have presented pre-elimination as a step before elimination. But I think it's very important to recognize that it may take many years for a country to actually get from pre-elimination to elimination. Next slide. And I've illustrated that by showing you that the arrows are not continuous but hatched arrows. If a country has a case rate of 800 new infections in children per 100,000 live births, it's obviously going to take them many, many, many years of continuous and consistent work and effort to get that case rate below 50 cases per 100,000. They're going to have to see a significant decline in the numbers of HIV-positive pregnant women, as well as significant improvements in the MTCT rate in order for the case rate to drop below 50. And my final slide just acknowledges some of the folks that have really helped, not only with the development of this presentation, but also in the development and conceptual work that has gone on behind the scenes to come up with the pre-elimination category. So I'll stop there. Thank you very much, Jessica.
Thank you, Shafiq, for outlining the criteria for pre-elimination and elimination. And I'm sure that many of the countries whom you've indicated might be eligible for pre-elimination. Appreciate the information that is shared. And to let everyone know, we will open for questions and sharing of any experiences or any comments after the 2 presentations. And without further ado, I'll turn it over to Dr. Innocent Nuwagira, who will talk more in depth about the actual processes that countries are required to follow, as well as the tools that have been developed to support the validation process. Over to you, Innocent. And I'll load the presentation right now.
Thank you, Jessica and colleagues. Thank you, Shafiq, for making my work a little easier, because now a lot of facts have been explained. So I will go straight into the next slide, please, into the the processes, what is required to be done. So by way of introduction, my talk will touch around the structures that countries will need to put in place, how they will link with those at the region and at the global levels, a little bit summary of the processes that will be followed, and then I will touch briefly on the 4 operational tools that are being put together, as Shafiq already said, that are still drafted, quite advanced but not yet approved. Next slide. So for countries that would like to undertake pre-elimination for those who are high-burden countries, or validation for those countries that are not high-burden, we would like they need to put 2 important structures in place. One is the National Validation Committee and also the National Validation Secretariat. While coming up with this process and the criteria of validating elimination of MTCT of HIV and syphilis, it was agreed globally that WHO offices at global, regional, and country levels will hope to serve as a secretariat. But I need to add quickly that this can be done in close collaboration with the other agencies and partners at country, regional, and global levels. So in terms of the National Validation Secretariat, the WHO country office will serve as the first point of contact with the national stakeholders. The WHO representative, in collaboration with other partners, provides all the necessary technical support to the country for development of their reports. Okay. And also, this same National Secretariat, when a country wants to request for pre-elimination or validation, the actual request and the report are submitted to the regional structures through the WHO country office. And as I said, in liaison with the joint United Nations program on HIV/AIDS and the joint team on HIV/AIDS at country levels. Now, the National Validation Committee, this is a structure that needs to be in place, and I need to add ahead of time that the Validation Committee can actually establish a validation team, which we are calling NVT, National Validation Team, which will be a team of experts that will move around the selected parts of the country to collect data, to analyze data, and actually write a report. So the National Validation Committee is established by the Ministries of Health in close consultation with the WHO and UN partner and other partners. It should be a multidisciplinary committee comprising of wide cross-section of professionals from various services, programs, and civil society organizations, including community of women living with HIV. Now, in summary, the role of the National Validation Committee will be to coordinate data collection, revision, and writing of the country report, but also serves as a counterpart to the Regional Secretariat and Regional Validation Committee and the Regional Validation Team for reviewing the national report and planning for implementation of the country validation follow-up and maintenance. Next slide, please. Those are the structures at the national level. At the regional level, there needs to be a regional validation secretariat. As I already said, this is managed by the WHO regional office in collaboration with other partners in the respective regions. Now, this secretariat establishes, convenes, and supports the regional validation committee or regional validation team. Also provides oversight to the regional and national validation activities and processes, communicates with the National Validation Committee and also the Global Validation Advisory Committee and Secretariat, while ensuring coherence and compliance with regional and global validation criteria and processes, but also monitors the maintenance. And I will be emphasizing this later on in my presentation, that it's not just being validated or pre-eliminated, but you must also maintain that status for you to keep a valid certificate. So Then the Regional Validation Committee. The Regional Validation Committee is convened by a regional director of WHO in that region. It advises the regional secretariat as to whether candidate country has successfully achieved MTCT regional targets of HIV and syphilis and whether it could be recommended for validation. In the absence of a regional validation committee, the regional WHO office will serve that function. And this is a situation where, for instance, a regional validation committee has not been formed in time, but something comes up and needs to be sorted in the area of MTCT validation. So the WHO regional office, as I said already, in collaboration with the regional partners, with the Global Validation Advisory Committee and Secretariat, can select a team of experts from amongst their region or their available experts to be able to review reports and take actions and recommendations of the Regional Validation Committee. In summary, the Regional Validation Committee evaluates candidate country MTCT reports for eligibility for validation assessment, determines compliance with regional and global validation criteria throughout the country assessments, and recommends countries for global validation or making suggestions for countries to address gaps or barriers to global validation that would have been identified through the validation process. Next slide. Yes, so at the global level, and Shafiq touched this already, there's a Global Validation Advisory Committee which has been in existence since around early last year. You are aware about the Cuba process, but just to summarize that the Global Validation Advisory Committee reviews the global tools, provides advice to the WHO Director General on whether countries should be validated, on whether processes and standards have been achieved, reviews regional validation reports to ensure consistency and compliance with minimum global criteria, and also provides guidance on ongoing monitoring in terms of maintenance of validation or pre-elimination, and provides independent advice to WHO regarding validation of candidate countries. And also at this level, there is a validation secretariat currently managed by WHO, but collaboratively with involvement of other partners. And also this secretariat provides the official notification of validation of MTCT to the countries and monitors the maintenance status. Next slide. This is to summarize what really, how the three structures link together at national, regional, and global levels, and the key functions that have got to occur at each of the levels. On my left side, we have at the top the National Validation Committee, which we have already said is assembled by the Ministry of Health in collaboration with WHO and other partners. And once the report has been prepared and the National Validation Committee is satisfied, then this report is sent to the Regional Validation Secretariat of the Regional Validation Committee through the country representative of WHO. Then the region reviews the report, plans validation or pre-elimination meetings, and this works collaboratively back and forth with the National Validation Committee to clarify things, to make sure things the exercise has followed the set standards. Once the Regional Validation Committee has done their work, then this report is sent to the Global Validation Advisory Committee, which reviews the report of the both written by the Regional Validation Committee, and also refers to the report written by the country and makes an independent recommendation to WHO Director General through the Secretariat on regarding the status of the assessment of that country and compliance with the set standards and criteria and processes. Next slide. Now, this slide, this and the next slide have already been touched by Shafiq, and he mentioned that I will come back to them. Go to the next one, Jessica. The point I want, no, back, one more. Yes, the point I want to touch on this slide is the question of maintenance of elimination or certification of pre-elimination. When a country has been visited, assessed, and given a certificate that it has pre-eliminated or eliminated, that's no reason for a country to sleep, because we've got to keep monitoring and reassessing. So maybe one can ask upfront, can a country be decertified? In practice, it should be, because if you have reached a certain rate, if you have gone and satisfied all the impact and process indicators, and 1 year, 2 years down the road, you have slept and there is no more compliance with global processes and criteria, then your certification will be subjected to review and a new decision could be taken. Next slide. So in the next couple of slides, I want to touch briefly on the operational processes and tools. Operational processes and tools have been revised, as Shafiq said. They are still draft, but they are being consolidated in a guide that will be once approved will be shared appropriately. But the main purpose of this compilation of these tools and operational tools and processes is to provide operational guidance for the implementation of effective and high-quality country validations that comply with global and regional requirements, and also to serve as a guide for new members of the regional validation committee, regional validation teams, country, and all this. So it's also a guidance and an orientation for the different structures we have seen, but also to assist country teams, that is validation committee, in preparing for the country validation reports. This, once approved, currently there are many sections, particularly the introductory section, which touches on all these structures and processes, but more importantly, the tools that I will go into details now. And these tools are, at the moment, there are 4. There's the data quality tool, there's a lab quality tool, there's a human rights tool, and a program assessment tool. Next slide. When it comes to program assessment tool and checklist, this is a tool, it's a series of questions, a series of criteria, series of areas that need to be addressed when you are doing a national assessment for pre-elimination or validation of MTCT of HIV and syphilis. So the tool is meant to gather information on the program and service delivery, whose main objectives are therefore to review the programmatic components relevant to the elimination strategy, such as antenatal care services, HIV and syphilis testing and treatment programs, treatment and care for infected pregnant women, their infants, and their spouses or partners. Assessment is based on the WHO framework for action to strengthen health systems and to improve health outcomes. You might be aware of the 6 health system building blocks, which include leadership and governance, health financing, service delivery, health workforce, medical products and technology, as well as health management information systems. Now, this tool also helps to verify whether the services are sufficient in scope, accessibility, and quality to sustain EMTCT targets. Next slide. So that was a summary of the program assessment tool. Now, when it comes to data quality tool and checks, this tool is used to guide the review, how to review data quality in a systematic way. It in particular assesses the reliability of the data generated by the country to evaluate achievement of the elimination targets and ascertains that the impact and coverage targets were achieved. So it's not enough to come up with a report. When the missions come for validation or pre-elimination, you want to make sure that everything as stipulated has been followed satisfactorily. Next slide. The next tool is the laboratory quality tool and checks and checklist. This is used to verify reliability of the laboratory tests, to make sure that tests are done of highest quality possible and that they are not reporting false results. Also to verify the existence of an adequate laboratory network to provide services needed to achieve and maintain a program for MTCT of HIV and syphilis, and also to ensure that the results generated by the laboratory network are accurate and reliable. Next slide. The next slide, and this also touches one of the important aspects of the validation of pre-elimination. You might recall in Shafiq's presentation, he said one of the criteria is to make sure that the elimination or pre-elimination has been achieved in a manner consistent with human rights provisions. So the human rights tool is to support discussions and review of key human rights considerations, particularly verifying that MTC targets have been achieved in a manner consistent with basic human rights, gender equality, and that communities are meaningfully involved in planning, delivery, and monitoring and evaluation of programs and services. So of course, this includes, among others, engagement with civil society, as well as networks of women, young people, and other people living with HIV and AIDS. And as Jessica introduced earlier in her introductory remarks, someone will be giving a little more details about experience of using this tool. My final and last slide is to acknowledge contributions that I've received from colleagues who reviewed this presentation and have contributed to its compilation. I thank you.
Thank you very much, Innocent, for that very detailed presentation on the processes and tools related to the validation process. And before we open for questions or comments, I'd like to give the microphone over to Miriam Chapimo of UNAIDS, who will talk a bit more about the human rights tool and how to ensure that the validation process or elimination criteria also includes upholding human rights. So Miriam, over to you. Thank you for graciously joining us.
Thank you. I hope you can hear me.
Yes, we can. Yeah.
All right. Innocent has already actually touched on the why human rights is a key consideration for validation. And part of the documentation that's required from countries is really to establish questions around the legal environment, which speaks to the United Nations human rights systems that are in place, the conventions, protocols, treaties, and other documents that have been adopted at global regional level as well as at country level. And of course, the gender considerations are key to ensure that the practices around gender norms and also the behaviors around groups and individuals positively influence opportunities for women and girls to access the necessary information and make decisions about their reproductive health to protect them against HIV and STIs. And of course, the community engagement really speaks to greater involvement of people living with HIV, particularly women living with HIV. And I'll probably just give you a little bit more information on the methodology itself, and also for the validation, which speaks to probably your preparations in your country reports, as you think of submitting a country report to this piece. That you should just follow the questions that are laid out on human rights, gender equality, and community engagement. And there is actually not enough time when the validation team comes in, the assessment team comes into country to do the assessment itself, to go into depth. So the team will rely on what you have documented, and they will be validating what you have written, not actually doing the investigation as to establish what there is. But what will be established are gaps in the responses, so it's important that the questions are answered as best as possible. Of course, the desk review will have been conducted already by the regional team, regional level, to review the regional binding, non-binding human rights and instruments that how the country has responded to these. And the country will also be approached to provide some details on this. There'll also be country reports reviewed, like shadow reports from NGOs, things like the stigma index, and there are a number of other documents, and countries can also be requested to provide these. And then the third part would be, of course, when we come in the country, is I shouldn't say we, when the team comes into the country to review to do the assessment, is that they'll have the tool speaks to two groups, government, and then of course and service providers, and then the civil society component. So the components, really, the way they work together is that you're almost asking the same information or asking the same questions to both groups. And when we went to Cuba, what we tried to establish was that the policies that governments understand very well and says this is what we have in place, that same information is validated downstream with the service providers and also at the community level, especially for women living with HIV. Do they understand that these policies exist? And if so, what do they mean to them, and how have they been implemented? And we need to establish some consistency that the policies have been met. And if they haven't, then that's just really to make a recommendation to the country to make sure that the policy is interpreted properly downstream and implemented. But if you're speaking now to the details itself and the tools, it's critical to know that you have to engage your civil society groups, your service providers in preparation of the report itself, so that everybody's on the same page. This is what Cuba did. They actually went and engaged all the community members, the women living with HIV, and brought them to speed on the human rights issues, so that they were clear what those were, what the policies related to those were, and then it was up to the civil society groups to then respond to us and say yes, they felt that those were being implemented or not. So if they're totally ignorant of the policies, then we do have a challenge, because then they're not being implemented. So on the human rights piece itself, the issues around the legal environment and criminalization of HIV transmission, those are critical. You have to document your status around that. And the responses at national level from the government counterparts should ideally correspond to what we hear from the service providers and from the recipients on the other side, the women living with HIV and the community. And then issues around mandatory or coerced testing for HIV or syphilis. What are the laws around that, and what protects the woman's right to refuse? So we wanted to establish, for example, in Cuba, that people have a right to refuse, and the women can refuse testing if they do not wish to undergo testing, and what are the mechanisms by which this is implemented. First of all, so the policy should be clear on that. The women should understand that. The service providers should understand that. And if there were gaps, then the subsequent recommendations will be made by the team. But there should be clear, informed consent, and what are the rules, policies, regulations that govern that, and how is the confidentiality, privacy protected. And then, of course, the other issues, other groups we asked, like migrants, are they denied? Migrant women, are they denied services, CMT services as a matter of policy, or is it open to all? And then we also established whether the networks of women living with HIV are involved in the development and evaluation of national policies and plans. And then, of course, you have to really state what the gender issues related to violence against women, what is the national plan or action or policy around that. And then, of course, if there are any grievances or mechanisms to redress those violations. For Cuba, for example, we actually went into the clinics and asked, so if a woman has an issue here and feels her rights are being violated, where would she go? And in the community, if that happened, where would she go? And they had to demonstrate how that happened. The level to which this assessment was done in Cuba was really in depth, and a lot of people were interviewed. But we anticipate for upcoming validations that it will be a much lighter process, but the key questions really should be addressed, and that's the most important thing. I will stop there. Thank you.
Thank you, Miriam, for sharing this information about the key important aspects of human rights considerations in the context of validation, including consent, confidentiality, the laws and policies that are in place, the involvement of civil society organizations, and what mechanisms exist to address any grievances, and for sharing your experience as you were intimately involved in the process of validation for Cuba. And in fact, this webinar builds on the earlier webinar we organized in July 2015 that shared in depth the experience and lessons learned from the validation process in Cuba, and which also informs a lot of the tools that have been developed and the criteria that have been discussed here. We have a few questions that have come in, and so I'll go through them briefly. The first was really around which countries are able to participate in the validation process, and is it only the countries who implement the global plan? And then linked to that question is Rwanda part of the elimination process? So I'll turn that over to Shafiq to respond.
Sure, that's a very nice and easy question. No, we've presented data on the global plan just because those are some of the higher burden countries, and it helps to illustrate the challenges that they face. But in no way is are the criteria for elimination or indeed pre-elimination exclusive to the global plan countries or indeed to any countries. They are open and eligible to all countries. The one thing that I maybe neglected to mention in the presentation, now that I think about it, is that the pre-elimination criteria, at this stage, we are imagining that these would be only available to countries that have a prevalence among pregnant women that is at or above 2%. And the rationale behind that is that it's really the high prevalence among pregnant women that is the main reason that is holding back some of the high burden countries from achieving their elimination targets. If a country has low prevalence amongst pregnant women, then really they shouldn't have any problem achieving the elimination targets, including the case rate. And so the pre-elimination category is not open as an option for countries that have low prevalence. Those countries should be applying for elimination, not for pre-elimination. So to the second question, absolutely Rwanda is being considered, and they are actively in the process of convening their national validation team to be able to pull together a report that they would then submit to WHO requesting certification. So I think that process is very much already underway.
Thank you, Shafiq. And a follow-up question is really a question of clarification, because Kundwani from South Africa is asking, in previous documents, 2 elements for pre-elimination criteria were outlined and related to the MTCT rate. One was the MTCT rate of less than 2% at 6 weeks, and then a final MTCT rate of less than 5% at 18 months.
This is Brian Levinson, your Fire Safety Director.
Hello?
On the 11th floor.
Yes, I'm still here, but there's some background
Yeah,
noise.
we have an announcement here at UNICEF. I apologize. I'll just stop until it's over.
Okay.
Shafiq, if you want to read the question.
11, 12.
Yeah,
Feel
no,
free to.
I understood the question. I hope you can hear me. The important difference here is that the indicator for MTCT rate is not intended to be a 6-week indicator versus a end of breastfeeding indicator, but rather an indicator of less than 2% in formula-fed babies in programs that are doing formula feeding, in which case the 6-week transmission rate would be acceptable, because in general those countries won't be able to report on an end of breastfeeding transmission rate because they're not breastfeeding. So the difference is not that the 2% is for the 6-week rate and that the 5% is for the end of breastfeeding rate, but rather that the 2% is for countries that provide formula and where formula feeding is the standard of care, and the 5% is for countries that are promoting breastfeeding. Sorry, Jessica, that's me over.
Hello? Sorry about that, everyone. There was announcements here at UNICEF coming through the loudspeaker that we couldn't control. So the next questions are really revolve around the process, and they're related to the regional and national validation teams. So there's a question on, is there a regional validation team? And I'm assuming this is referring to Africa, as the question is coming from South Africa. And who is part of that team? And related to that, there are questions around the timeline for the global validation team, and when will they officially communicate to countries that do qualify for pre-elimination? So what is the timeline for that? And as well as there's a request for terms of reference for these various validation teams at the global, national, and regional levels. Innocent, would you like, or Shafiq, would you like to comment on that?
Okay, Jessica, let me talk about the regional validation committee for Africa, and then Shafiq will say when they will communicate to countries. I don't think I understand the question though. But Kondwan, thank you for nominating me to the Afro regional team, because the question says, is there anybody else apart from Innocent? Just to clarify that I'm actually not a member of the regional validation team or committee, because the regional validation committee has not been put in place. But also want to add that there have been discussions recently with the Office of the Regional Director and the Director for Family and Reproductive Health and the different relevant technical officers at least we have agreed to put in place a regional validation secretariat, which will be headed by the regional PMTCT advisor, and a lot of other people will be part of this secretariat, including possibly from other UN agencies that are very active in the region. With respect to the validation committee, the regional validation committee, during my presentation I said, if a regional validation committee is not yet in place, and by the way, I think we added, and myself and Shafiq said, that a regional validation committee is optional. Some regions, in fact, have opted not to have a regional validation committee. But where a regional validation committee is not in place, then the regional validation secretariat, working together with a roster of identified technical experts and with support from Global Secretariat and Validation Advisory Committee, then they perform that function. So for Africa, we are still discussing different modalities. But for sure, what I can say is, if there is a country that needs to be validated or pre-eliminated, once you have submitted your report through the WHO country representative, it will come to the regional office and it will be attended to because the secretariat is almost already constituted. Over to you.
Shafiq, would you like to add anything?
Sure, yes. Thank you very much, Innocent. As you can tell, colleagues, this is still a work in progress, and it's because this is all quite new that we have not as yet put anything official out about the pre-elimination concept. Although, as you can see, the ideas are pretty well formed, and I think most of the key participants and certainly the countries that would be eligible for pre-elimination are already aware of these criteria having been proposed, even if they're not finalized. The timeline for coming out with the final policy brief on these criteria keeps changing, but we're still hoping that we might be able to get something out in the first week in April as an official communication that says, you know, pre-elimination exists and these are the criteria. But of course, what we do know for certain is that although we can't be clear on exactly whether it's 90% or 95% for these criteria, we can definitively state what the actual elements will be. So we know that we're going to be looking at ANC coverage, at testing coverage, and at ARV coverage for PMTCT. We know that we will want to look at both estimated and program measures of the final MTCT rate, and we know that we will want to be seeing calculated case rates for the numbers of new infections in children per 100,000 live births. So those elements are set in stone, and what that means is for the National Validation Committee and the work that they have to do to create the country report, there's really nothing to stop them from beginning to evaluate their programs, from gathering the data that will certainly be required to be submitted as part of that national report. So it is a shame that we haven't been able to come out with the sort of final definitive criteria, but I think in practice this has not held up country discussions and the ongoing development of country planning around making submissions for requests for either pre-elimination or elimination. I'm happy to take additional questions on that if folks want further clarification.
Okay, thank you, Shafiq. A couple of questions before we wrap up. One is, can you explain the rationale between linking EMTCT to syphilis?
Yeah.
And then the second is, based on Cuba's experience and spectrum estimates, can you give a sense of the number of years it might take to go from pre-elimination to elimination, especially in high-burden countries? And then what is expected around PrEP and uninfected pregnant women?
Yes, all very good questions. The first question was related to. Sorry, I missed the first question. Actually, I wrote down number 2.
Sure.
Remind me of that.
Rationale, the rationale between
Syphilis.
EMTCT and syphilis. Yes.
Yeah, I think that's a good question, and I just want to remind us that we have launched global efforts, including in the Africa region, to drive towards the dual elimination of mother-to-child transmission of HIV and syphilis. And the syphilis part has become relatively sidelined by the sort of emphasis and focus on the prevention of HIV transmission. But when you look from a global perspective, syphilis and congenital syphilis actually now accounts probably for more global burden of disease, more perinatal mortality than that which is related to HIV. So I think that was the rationale behind wanting to remind countries that this is something that's important. It's important for the health status of women and children in the country. And since there are real opportunities with the recent approval and pre-qualification of dual tests for HIV and syphilis, and since treatment for syphilis to prevent congenital transmission is really so straightforward, it involves basically a single dose of benzathine penicillin given to the mother, that we felt now was the time to underscore the value of using the PMTCT platform to leverage it to be able to push towards controlling the prevention of the transmission of syphilis as well as of HIV. So I think that was part of the rationale behind it. In terms of the timeline that one might anticipate a country should be taking, I think that's going to depend very much on where that country starts. And as I demonstrated on the slides, for some countries, the number of cases that are seen annually are very, very high. In some cases, over 1,000 new child infections per 100,000 live births, even in a country like South Africa, where there's been tremendous effort to scale up services. We're still seeing a case rate that is much above the threshold for elimination. And so I think the decline in case rate is something that will have to be individually determined by a country's epidemic status. And the idea behind the Elimination Plan was not to define a particular time frame in which that plan must be rolled out in order to achieve the low case rate criterion, but rather to present a plan that is feasible and reasonable, that touches on the elements that I've highlighted, which we think are really important drivers of ongoing mother-to-child transmission, sort of the unfinished business, really, of the work that we've done around preventing mother-to-child transmission. So I think that the plan should definitely cover those important elements. But at the same time, we did not want to stipulate a time frame for when a country must try to achieve those things. And incidentally, we're also working on what I hope will be a very useful and practical tool for countries. It's a model that will allow countries to input their current epidemic data and then actually toggle different interventions that they want to take to scale and set the time frame in which they want to implement those interventions. And what the model will then output is how those series of interventions will actually drive the case rate down, and over what time you can expect the case rate to be driven down. And so we think that what that model will allow countries to do is to actually sort of play with various different parameters and different interventions, and be able to assess for themselves how their national programs will actually be able to achieve low case rates and over what sort of time frame, and then build that into the elimination plan that they submit together with their proposal for recognition of having achieved pre-elimination status.
Okay, and I think the last question, did you respond to, Shafiq? Around
I apologize.
expected, around PrEP and uninfected
Yes.
women.
So this is obviously an important and emerging area for us within WHO. The current PrEP guidelines do not exclude pregnant women from being candidates for PrEP if the incidence amongst those communities exceeds the threshold of 3%. So we do not believe that there is a rationale not to use PrEP in negative pregnant women, and the guidance already currently states that. However, there are of course concerns around the safety of giving PrEP to women who are pregnant and who are not on AR, who don't need the drugs for their own health. And whether, potentially other strategies might be important to also incorporate. And I certainly don't want us to give the message that PrEP is the only option for preventing incident infection. There are clearly other things that we can do, including a better job of partner testing, so that we pick up women who are HIV negative and ANC, but who have discordant partners, because I think that's an important source of incident infection among those women, and so potentially there might be value to getting smarter about doing partner testing and partner treatment to try to address incident infection. So I think PrEP is one of several interventions that one could think about to reduce that risk of incidence. But this is an area of ongoing work. We're actually convening a meeting next week that will touch on this here in Geneva, and there will be other meetings that have been planned for later in the year to specifically formulate stronger guidance around this particular clinical scenario, and what concerns, if any, should be put in place before women are enrolled on PrEP while they are negative and pregnant, or indeed negative and breastfeeding, because as you know, breastfeeding continues for a long period of time, and that is also a long period of time during which incident infection could occur and pose a risk to the infant in terms of transmission. So an emerging area of work that I think we're going to see a lot more definitive recommendations on over the coming months.
Okay, thank you so much, Shafiq. And I think the presentations today really outlined and underscored the fact that there's been much emphasis on improving access to ARVs for pregnant women in an effort to reach the elimination targets, and going forward to be certified for elimination. It's going to be equally important to really expand that focus to include prevention and to focus on the other pillars of comprehensive PMTCT services and programs. So a very sincere thank you to Dr. Shafiq Asaji and Dr. Innocent Nuwagira of WHO and Miriam Chapimo, of UNAIDS for joining us today and for giving us these very timely presentations on the pre-elimination and elimination criteria, as well as describing the processes and tools that are in development. I know we usually share materials following the webinar. In this case, however, these presentations are still being finalized and approved, and as Shafiq said, they will be officially shared and communicated very soon, and probably sometime next month. So thank you for your patience and understanding with that, and thank you all for your time and attention, and we look forward to continuing to hear from you as some countries might start to participate in the pre-elimination process in the near future. So again, thank you to all of the presenters. Any last words from our presenters?
This is Innocent. Thank you, Jessica, and all for attending. I'm really excited that so many people came and attended this webinar. Maybe, I don't know how the timing is, you may consider something, a repeat of the same, maybe when the final tools have been released, so that we can go through the very final versions of this. I don't know. That's just food for thought.
Okay, thank you. Shafiq and Miriam, any last thoughts?
No, just to echo what Innocent has said, thank you very much to all of you who paid such close attention. I know that this is an area that has been the source of some confusion and excitement, so it was good to be able to connect with folks, and we will certainly work on the official communication. I know that that's been a stumbling block for many countries, for many of us that are working in country and that are trying to have sort of communication with ministries around this topic. And so we will strive to get those out as soon as possible. And I think if there is a specific country setting where it would be valuable to have some official word from WHO even before these are finalized, then please do reach out to me, and we can maybe think about how to provide that input outside of the sort of standard and formal process.
Can I add, Jessica, that we are still available to answer any more questions? They can pass through you. They can come directly on our emails. We'll be there all the time to support countries and partners.
Great. Thank you, Innocent, for being available to answer any follow-up questions. And certainly you can send an email to the Community of Practice, and we will make sure to forward your questions and comments to the appropriate people.
Great.
Okay. Thank you again for your time and attention. Have a great day, and we hope to see you soon online. Thank you.
Thanks, everyone.